Thank you very much, Bernd, for that very nice introduction, and thanks for inviting me to this great session, and also to talk after the distinguished guys, Niklas and Ben. And I also, like Ben, I want to congratulate Niklas with, again, performing a large trial on this difficult cardiac arrest population, and I congratulate you with that achievement. So I will touch on some of the same aspects as Ben touched on, but I will try to put it in a complex. We all have to know that cardiac arrest is not straightforward. It's very complex. It consists of several different causes. Many are untreatable, irreversible, and extreme challenging. It's a large heterogeneity among the patients, and the patients are threatened by these limited crucial time intervals due to the hypoxia and extreme ischemia. And there are large differences in quality of care between hospitals. Also, hospitals that participate in trials like the TTM2 trial, there are large differences in quality of care, and there is a very high mortality. And we have to acknowledge that several of the included patients in our trial already have an irreversible neurologic injury present before we randomize them. And of course, research in such patients is futile and will not provide crucial answer. And in addition, we include also patients with very short arrest times. And a lot of these patients are patients in the TTM2 trial, and they have minor reperfusion injuries before randomization and allocation to treatment. And of course, also research with the therapy impacting on the reperfusion injury has no or minor effect and will not provide crucial answers for the total cardiac arrest population. So this is not straightforward research in these patients. Well, I work in Oslo, and as you can see here, I started actually my career as a researcher on cardiac arrest in 1996. And this is the outcome improvement over the years, as we have seen in Oslo, as we have seen all over the world. And you can see here in the 90s, we had really poor ALS, and we all had really poor post-arrest care, and the survival was low. But in the time, we improved the quality of ALS, and we had some improvements in survival. But it was first when we introduced the post-arrest patient care strategy after the HACA trial and Bernard trial in 2002, when we introduced standardized treatment protocol, that really the survival doubled in Oslo, and it has stayed in that level. So it has been shown over the last 20 years really improvements in survival due to better care, and especially due to better care also in the hospital. And hypothermia is part of that. And I will now touch on the last chain in the chain of survival and summarize some of the reasons why hypothermia has worked. We would say hypothermia here the last 40 years. And there's been tremendous work on animal models, and they, in the majority of these studies, show reduced metabolism and oxygen requirements, which is especially important for the brain because the majority of these patients die due to the brain injury. It inhibits the reperfusion injury, has been shown in several animal studies, and 32-34 is better than normothermia. Hyperthermia is detrimental, and importantly, time to hypothermia initiation is important, as Ben also stated. We know that if you delay cooling, you will have reduced or lost effects. So there is obviously a therapeutic window in here. This has been very nicely summarized in a recent systematic review and meta-analysis of animal studies from the Vienna group, where they concluded that if you look at all studies regarding neurologic outcome among all these animals, it favors TTM, deep TTM, compared to control or normothermia. In another recent meta-analysis from the TTM group, they also showed that TTM is beneficial under most experimental conditions in animal models. But they had some statements that research on neuroencephalic species like humans or big animals, and especially comorbid animals, is uncommon and a possible translational gap, and that the low study quality suggests risk of bias within studies. They also claimed in the conclusions that future animal research should focus on mimicking the clinical scenario and employ similar rigor in trial design to that of model clinical trials. Well, to the last statement, I really disagree, because what I really think we should do is do the difference. We should learn from the pathophysiology from the animals and take that into to try to optimize the treatment, and perhaps not do it in a pragmatic fashion. And also to answer that question, I think a lot of the animal studies have actually shown that if you delay cooling, like we do in a lot of the clinical trials, you will have no effect, or you will lose the effect. I will come back to that later. So there are large differences between animal data and clinical studies. You can see here the tight protocols in the animal studies, so that the groups differ quite fast. Here you can see the mean values, as Niklas also talked about, +2 standard deviation from the TTM1 trial. And this 0.0 here is not time from cardiac arrest or ROS. This is time from randomization. And as we heard, they had 240 minutes. That means 4 hours from ROS, and the arrest happened sometimes 30, 40, 50 minutes before that again. So the time from arrest until cooling actually was started was very long. So the groups were very similar in the early phase. So that we might lose the effects based on that. In the TTM2 trial, you can actually see that the difference between TTM and TTM2 is not very big. It's the mean values difference is less than 1 degree, so very similar. But now they reduced at least the time to randomization from 4 hours to 3 hours. But this might impact the data. We don't know that. And again, the clinical studies are very different than the animal models. So what kind of trials are we doing? I mean, if you look at RCTs, there are 2 kinds of trials. We have the explanatory trials, like the HACA trial 20 years ago, and we have pragmatic trials, like the TTM trials. Well, the explanatory trials shows an effect of a particular intervention in a controlled setting, with focus on homogeneity, with extended inclusion and exclusion criteria, and on a clearly defined population. So these are efficacy trials, if and how an intervention works. But today, we actually jump immediately. We do that in cardiac arrest, but we also do that in all the ICU trials we do today. We jump immediately to pragmatic trials with large heterogeneity, large and simple in their design, to get as many patients as fast as possible. And quality of care is not so much in focus, because everyone can do what they do. That's part of the pragmatic trial. And this is whether an intervention actually works in real life, so it's effectiveness trials. So if we should try to document if an intervention works, I think we should run to explanatory trials first, and then perhaps later do pragmatic trials. Because also the pragmatic trials have the patients that we include in these trials, as Ben also showed, have huge differences in the reperfusion injury, in the brain injury among the patients. And also in the pragmatics trial, as we just saw from the results from Niklas from the TTM trial, there is a lot of patients that were not randomized before 180 minutes. And a lot of the trials that included patients in the TTM2 trial and also in the TTM trials only had very few patients, so there must be some kind of selection in here. There are also huge differences in quality of care and the methods used. I'm not saying that the TTM2 trial is a bad study. It's a very good plan. This is perhaps what happens in such big trials, but this kind of opens up the scientific discussion around the results, at least in my opinion. So as Ben touched on, after publication of the TTM trial, a lot of sites around the world changed their practice to 36. And this is what happened in Australia. You can see here, this is a mortality in Australia that went down. And here is the publication of the TTM trial. And you can see here that the mortality starts to increase again. And this is just mortality. We know that the major impact of hypothermia is on the reperfusion injury, on the neurologic function. So when you see data like this, you get a little scared because this is in a registry. We have all the patients in the randomized trial. We only have those patients that we include in the trial. And has been very nice summarized. These are all, and these are data from different studies evaluating changes in practice after publication of the TTM trial. And if you look at mortality, there's actually no difference among these studies. But if you look at neurologic outcome, there is a significantly actually better outcome. If you look at all these trials, observational studies that appeared after the publication of the TTM trial. So again, we have to be open and say, of course, in several sites there were no difference. In some sites, there were worse outcome after changing to 36, but in no studies after changing to 36, the survival have been better. So it's either neutral or worse after changing to 36. And the degree of injury impact. This is a Pittsburgh study that Ben showed you. And what they did in this study, performed by Clifton Calloway, who also took part of the TTM2 trial, although they only recruited 2 patients. But what they did, that they tried to divide the patients into different kinds of severity groups using the Pittsburgh cardiac arrest category with PCAC 1 to 4. And they excluded all the patients with a really futile prognosis, those with a severe cerebral edema, and those with the presence of highly malignant EEG in the early period. So they ended up with patients that only with a fair chance of survival that were cooled to 33 or 36 degrees. And as Ben showed you, you can see here the different PCAC models. These have low reperfusion injuries, and these have a more severe reperfusion injuries. And you can actually see that among those with a lower reperfusion injury, the outcome was actually better in the 36 group than the 33 group. But in those patients with a moderate to severe reperfusion injury, outcome, neurologic function here measured with a modified ranking scale, was better in those patients with 33 compared to those with 36. So the degree of the reperfusion injury seems to impact on how this treatment works. And that fits also with the pathophysiology of how hypothermia should work. This is a Japanese study which actually did the same, although they used another method to score their patients. They used the AirCast score, where they used the initial rhythm, time to RUSC, blood pH, serum lactate, and GCS motor score at time of RUSC. And they graded the patients in the low injury, low severity, moderate severity, and high severity. And again, among 1,100 patients that were cooled to 33 and 36 degrees, they saw among those patients with a low severity that there was no difference, actually a trend towards better in the 36 group. But with those patients with a moderate severity, it's significantly better outcome among those patients cooled to 33 than those cooled to 36. And also you can see here on the same curve how this impacted on survival. You have a moderate to severe injury. Among those patients with a very high severity, of course, the survival was low in both groups with no effect of hypothermia. They also did a propensity score matching where the results were the same. Lower hypothermia to 33 to 34 had better outcome compared to 35 to 36. And they also did a sensitivity analysis, which showed exactly the same. Among those patients with moderate severity, the outcome was better if you cooled deeper than kept to 35 to 36. So the degree of the severity of the injury impacts work. And we also know this Hyperion trial from France, which really consists of patients with a more severe injury. This is a randomized trial where they compared 33 to 37 degrees among patients with non-shockable rhythm with a way more severe prognosis. You can see here the mortality is way higher than in the TTM trials, but still there was no difference in mortality between hypothermia and normothermia. But if you look at neurologic function, the results were better in the hypothermia group, significantly better compared to normothermia. So if we try to summary TTM after out of hospital on neurologic outcome, we have the animal data that clearly states that hypothermia to 32 to 34 is better than normothermia. If you look at the RCTs, the HACA, the Bernard, the TTM, the TTM2, and the Hyperion, it favors TTM or it's neutral versus TTM36 and normothermia. If you look at all the observational studies after the TTM trial, it favors TTM or they are neutral versus TTM. And then we also have all these important clinical factors that are impacting on outcome. For example, the degree of the reperfusion injury, as I talked about, then the timing, duration of TTM, even methods of TTM impacts. If you use a temperature control device, outcome is better than if you don't use a temperature control device, has been shown in a recent meta-analysis 2 years ago. And what about the self-fulfilling prophecies? What about bias? We have bias in all trials. We have bias in the pro trial. We have bias in the animal trials. We have bias also in the TTM trials. There are biases. For example, I wonder if we look at, for example, the point about awakening. If you look at the TTM data, actually the time from randomization to ICU discharge was exactly the same in both groups. And also the time of treatment withdrawal was the same in both groups. And if you consider the impact of the pathophysiology of cooling patients down, you will have a later time to awakening. We showed in an Oslo study that time to awakening was median 6 days. And if you stop treatment based on patients in coma too early, you are really pulling the plug too early, that a lot of people talk about. And in my opinion, that will affect the hypothermia-treated patients more than the normothermia patients due to the pathophysiology and the fact that deeper hypothermia impacts on time to awakening due to sedation, kidney affection, and so on. So the self-fulfilling prophecies might impact, and also the quality of care. And this altogether complicates the scientific interpretation. And what about also, like when talked about, all cardiac arrest patients not filling the TTM inclusion criteria? So I don't think this is black and white. I think this is I don't think this is a one-size-fits-all. So let me finish by just citing the editorial from Laurie Morrison and Ben Thomas in the New England Journal of Medicine. The future is patients should be more patient-centered. Our one temperature target may not meet the needs of all patients without hospital cardiac arrest. And the target temperature at the discretion of the clinician could be, based on what we have heard today, could be 33, 36, or below 37.5. And I always quote, when I talk about recitation science, this fantastic verse from Arthur Sanders from the editorial New England Journal of Medicine, 2011. The goal of recitation is saving lives. Research helps achieve this goal, but it's not the goal in itself. And I hope that we will think a little more about that in the future, because we want to save more lives, not to create more frustration. And with that, I will just have an analog from newborns. We know that hypothermia also works in newborns. Several RCTs have been showing that. Several evidence, moderate hypothermia is better than normothermia, although they cool for 72 hours. But they state that this has to be done in facilities with the multidisciplinary expertise, equipment, and protocols, and commence within 6 hours of the hypoxemic ischemic insult. And actually, they did a study where they delayed cooling in newborns with 6 hours, and they lost the effect. So timing, again, is very important. Thank you.